Just give me a second. Let me just.
Shilpa will start.
Good to go, sir.
Okay. Good evening, all. On behalf of ISA Karnataka, I welcome all the postgraduates and delegates to 20th ISA Karnataka webinar. I welcome President ISA Karnataka, Dr. Manjunath Eddi, Vice President Dr. Nazir, Editor Karnataka Journal of Anesthesia Dr. Sudesh Kannan, Academic Advisors of ISA Karnataka Dr. S. Palabhaskar, Dr. Gurudat Sir, Dr. S.B. Gangadhar, Dr. Ravi, and Academic Chair Dr. S. Vijayanand, and Dr. Danish Azam. Today's session will be moderated by Dr. Azam Sir. I welcome today's speaker, Dr. Natesh Prabhu and Dr. Sumalata. Welcome you all. Over to Azam Sir.
Thank you, Shivkumar Sir. Good evening, everyone. Welcome to monthly online academic program. We are running the number 20th now. And today we have speaker Dr. Natesh Prabhu. He needs no introduction. He is Associate Professor, Department of Critical Care Medicine, St. John's Medical College, Bangalore. His special interests are being hemodynamics and advanced hemodynamics. He is into critical care education and simulation based training. He has a special interest in critical care sonography, that is point of care ultrasound, and with other special interests being mechanical ventilation and critical care nephrology. He has more than 30 publications, and welcome, sir. You can share your screen and start the topic, sir. Thank you so much.
Hello, everyone. Am I audible now?
Yes, sir, you're clear. But we cannot see your screen, sir.
Is the slide visible to everyone?
Yes, sir.
Thank you. At the outset, I thank Manjunath sir and Dr. Shivakumar and Dr. Azam and Ravi sir and everyone for giving me this opportunity. It's a great pleasure to be here. And without any time delay, I just start my lecture. So the today's the topic is principles of fluid therapy in critically ill patients. And if you see here, fluid therapy is a commonest intervention done in intensive care unit. And every day, at least once in a while, we give some kind of fluid to our patients. Even though the fluid therapy has been known to give what are the complications and how to choose a patient and a correct time, correct therapy, so many controversies still exist. And fluid is rightly said, it is a drug, and you should be very cautious in giving fluid therapy, especially the dose of fluid and the time and how you are monitoring the patient. So today is my goal of the lectures will be, and mainly to give a conceptual framework of the fluid therapy, especially pertaining to the critically ill patients, to understand the physiology and which fluid when to give and how we are going to give and how we are going to monitor. Few are my opinions. I'll be keep telling when I'm giving opinion, and I'll be trying to quote few evidences and in between. So why actually we are going to give fluids? It's not that every patient we want to give fluids. There are certain goals behind giving fluids to a patient. The prime purpose is to maintain the tissue perfusion of the organs. That is extremely important, and to maintain electrolyte and water balance. And last thing is to maintain the normal glycemia. These are the key anchors of any fluid therapy. Why are we giving the fluid therapy? The problem is once you know the goals, and the question is which fluid to give. To
Nitesh
answer
sir,
this, I will
sorry.
ask the question: what is the purpose? Why are we giving fluids? Yes,
You can switch
yes,
off your
please.
video. I think there is a lot of lag in your voice also. If you can switch off your video, I think it will be a little faster. Thank you, sir.
Okay, fine. Yeah, thank you. So, which fluids to give? It depends. So, if you see resuscitation, you are going to resuscitate a patient, and the fluid choice is completely different compared to choosing a fluid for a maintenance therapy, as well as replacement or some special purpose, like to deliver the drugs like amphotericin we given dextrose, and patwas we given dextrose, phosphomycin we given dextrose. So depending upon, so what is the purpose? So the fluid choice depends. So to understand that, we should know this basic physiology, and by and large for a 60 or 70 kilogram and normal human being, 42 liters of total body water is different intracellular and extracellular, and everyone knows finally the intravascular volume is only 3 liters. If you see the fluid compartment, two-thirds the fluid is actually in the inside the cell, intracellular compartment. It has a lot of osmolar particles. Primary is proteins. Interstitium and an intravascular compartment become the extracellular space, and majority of we are more interested in these compartments, and especially in a critically ill patients. To be example, if you are going to infuse 1 liter of crystalloids, like crystalloids means isotonic, for example, normal saline or ringal lactate, what will happen? So 1/4 will be intravascular and 3/4 will be interstitial. And more or less, it is not going to enter the cell. It is going to be stay away from the cell, but some amount of volume, very minor volume, may enter the cell itself. If you see the composition, 750 ml in the interstitium and only 250 remains in the intravascular. Similarly, if you give a colloid, what will happen? 1 liter of colloid. So majority of colloid stays intravascular, but the problem is it is going to suck more fluid from the cell as well as extremely high fluid from interstitium. Even though we are happy in fulfilling the intravascular volume, finally the sufferer are in cell as well as interstitium that become dry. That is going to cause more problem. One way you load the compartment with fluid, other way you dry the cell. So that also is not good. But by and large, in case of sepsis or probably critically ill patients, the membrane is not tight. It is going to be more leaky. So especially in septic shock patients, leaky membrane, lot of edema forms. What will happen is cholera also will enter the interstitial compartment, causing tissue edema. So contrary, if you give a dextrose, so what will happen? Majority will go inside the cell. So whenever you have an intracellular dehydration, we prefer to give a dextrose, that is water, especially in hypernatremia, so that it enters the cell. So these are the common physiology actually we should remember when you are actually choosing the fluid. So I want to give a case a scenario. Commonly we see 34-year-old male AML on chemotherapy, and usually chemotherapy patients are very sensitive for mucositis. Because I have chosen this case because we recently came across nearly almost 10 months before, and who came to ER with a fever, abdominal pain, and loose motions. And it was a watery loose motion as per the description of the patient. Patient was tachycardic, he was hypotensive, had a cold peripheries, and abdomen is not so tense. It is slightly tender but decently soft. The first ABG that is done in emergency room, metabolic acidosis was there, slight hypoxia was there, and very high. If you see phases of shock, it is a conceptual molar. So SOSD or probably Rose concept will tell. So initial few minutes, patient usually will have a severe kind of a shock. A phase will be there, and after that, usually we'll have an optimization phase of shock, and you usually try to stabilize the patient. Once the patient is stabilized, we try to de-escalate water the fluid given. So any patient who is coming in a shock, we resuscitate the patient initially. We pump in fluids. So as much as fluid patient requires, and once the patient is slowly getting optimized, obviously patients will be given antibiotics. His source of sepsis will be tackled. He'll slowly will improve, and all patients will go through some kind of a peripheral edema. Inflammation will come down. slowly will go into recovery phase. That time, when the patient is completely hemodynamic stable of vasopressors, we try to de-escalate with Lasix if required. So this is called evacuation. These phase actually almost every patient who is coming in shock will go through. But the problem is this phase is not completely rigid. It is quite arbitrary. You cannot differentiate all these patients, all patients. But this is a concept we should know, because the charge of fluid and the volume we're going to give is going to completely different based on this timeline. So when to start fluid, it depends upon which fluid. You're going to see the first part, salvage. That is, we're going to resuscitate a patient. Obviously, your aim is actually to make a positive balance, to make the hemodynamics stable. That is to get acceptable map. So it is a crisis scenario. So getting a positive balance is extremely important. That is our goal. So here resuscitation, that means the purpose is to achieve hemodynamic stability, number one, because inadequate resuscitation leads to continued tissue hyperperfusion that will aggravate your organ dysfunction, and the patient will go to multi-organ dysfunction, ultimately death. So correction should be very early. So early correction of hemodynamic instability and maintaining the tissue hyperperfusion is extremely important. That is going to improve the outcome. Here, because we are going to resuscitate a patient, the fluid should stay in the intravascular compartment. The whatever fluid are going to choose should be a type that it stays intravascular. So if you see that I showed, crystalloid stays maximum intravascular of up to 1/3, and colloids almost nearly 70% may stay intravascular. But which one to give? The commonly used crystalloids are saline, ringalactate, balanced crystalloid to name plasmalite. We use critical albumin, and other structures almost we are not using at all. So which one to give? So a lot of literature. This is the very old study on 10% pentastarch. So 10% pentastarch has never been used nowadays. It is done in Germany. They found no difference in mortality, but they found a lot of hypoglycemia were there. So more harm if you give more fluid. So that was the conclusion. And they found a lot of kidney injury patients require more dialysis. Next is a chest study. They used a little lesser percentage, 6% hydroxyethyl starch, volume 1 was used. They found that again kidney injury was more, lot of dialysis were there. So what the next study did is 6% starch. They tried to use 130 versus 0.4 formula, especially in a severe sepsis and done in Europe. What they found is no difference in kidney injury. So a lot of literature imbalance were there. There was some pro-steroid, pro-colloids, some were against colloids at this point of time. Then the major study came, success trial. This is one of the largest trial done in Denmark. So success they used, and 804 patients. So primary outcome was death, and the secondary outcome was death at 28 days. What they found is if you use more starch, that is hydroxyethyl starch, lot of death were there and more RRT. After this trial, the interest of using starch actually has came down. And until next study, they use a different colloid study that is done in Australia. Usually Australian RCTs will be very large volume patients will be there. You can see almost 7,000 patients, largest trial of fluids. So what they found is the safe study found safe in the sense albumin and saline are almost equal to each other, and they didn't find any major harm with saline. But one thing is, if you see patients with trauma and TBI, if you give saline, that actually was much better compared to albumin, because they used 5% to 4% albumin. That was slightly hypotonic compared to your plasma. So giving a hypotonic fluid in a TBI, it's a little contraindicated because it is going to increase your cerebral edema. That was the actual explanation given. So they showed the data that except TBI, especially in sepsis and other patients, albumin may be safer compared to normal saline, and but not in trauma patients. So either use saline or albumin. And another important thing I showed here is it's a post-hoc analysis, because the TBI actually was not the pre-specified group. It is a post-specific group. So we have to take little pinch of salt. But even though it has shown it has a large margin of difference it showed, TBA patient actually lead to higher mortality, then we should be more safer. And Albios is a trial specifically targeted to only septic shock, because here we know that we should not use TBA patients. So severe sepsis and septic shock, they found no mortality difference. But in patients who are not having only sepsis, but with the complication of septic shock, they found mortality benefit. The tools a post hoc analysis. So next interest came towards more of a plasma light. So rather than telling more of a colloid, people started using more of a plasma light because they found a lot of high chloride in normal saline and a lot of kidney injury were there. So this also was done in Australia. What they found finally is no difference in acute kidney injury risk, but the problem is a lot of surgical patients were there compared to critically ill patients. Then they found that probably instead of actually using saline, plasma light could be an alternative, but saline was much cheaper. Smart study actually was in critically ill patients, lower AKI, and this is a SALT ED trial. This is more in ED plus WAD. They found a lower AKI. After these three trials with meta-analysis, they found that if you use saline, there is chance of more kidney injury compared to plasma light, balanced crystalloids. But the problem is with the pinch of salt, we have to see it is not that only plasma they are used. So it's only a specific period they use plasma light. Rest of the time they allowed all crossover. So it is hard that only one fluid can be chosen for a patient. So it is not easy that you give only plasma light throughout the ICU stay. It is not feasible. Throughout the OT hours, it is not feasible. Throughout the post-op period, it is not feasible. So all this trial was not feasible. And recently, a few months before, one more trial came, and that is the largest study comparing balanced crystalloid versus the normal saline. I didn't include here, and that also didn't show any difference in mortality, no difference in AKI compared to normal saline. So by and large, if you see the choice of fluid, to make it in short, critically ill patient, we prefer ringalactate. Plasma light, probably it's upcoming. I feel that plasma light may not be actually suitable because it's more costlier. And lingalactate has shown almost equal. It is not shown any major harm in any trials. And the majority of trials are head-on with normal saline. And ringalactate, it's also decently considered as a balanced crystalloid by many people. If sodium is low, it's logical to use normal saline. If you're going to use larger volume, probably colloid can be considered. If you are going to use colloids, don't use 20% albumin, use 5% albumin, and don't use any other starch. Especially renal failure is high risk if you're going to use starch. TBA patients, still normal saline is the gold standard, don't give albumin. So, but the problem is fluid is not always actually safe. It is has its own limits. We have to actually see it. One side, if you are worried about hypovolemia, if you don't resuscitate a patient, complication are more. Otherwise, if you give more and more fluid, it is going to cause more fluid overload. It is again going to cause a lot of hypervolemia related complications like pulmonary edema, limb edema, skin peeling, and sometimes very difficult to wean a patient with a large volume load. And all these problems can happen. But make sure that we have to stay optimal. So to tell it is completely easy, but it's very tough at the bedside to stay optimal, because during initial phases, patient may consume a lot of fluids. But once the patient is getting stabilized, he may not be completely good enough to remove water. And when patients actually become better and better, it takes time. So he's going to go through phases. But one thing we can do is, rather than giving excess fluids, we can slowly titrate and give fluids so that whenever required, then only give. Rather than giving larger boluses, small boluses we can give. So always you should make sure that our patient stays in the limit. So you have to stay more balanced here. So how much to give fluids? That is a $1 million question. No one knows whether to give liters, probably 2 liters average, or ml per kg. Initial studies were targeting early goal-directed therapy. So you target mean arterial pressure, or you target lactate ICO2. Is the 2001 trial? This was the landmark trial that changed the practice early goal-directed therapy. First 6 hours you give good fluids. So there was a heavy mortality difference was there. But the problem is dosing of fluid and how much and how early, we don't know. So surveying sepsis camping in FUSI, protocolized resuscitation, it is based on that trial I showed you, reverse trial. So you target achieve CEP, target to achieve a mean arterial pressure or urine output or SaO2. So you keep giving fluids until you reach this target. But the problem is this is not going to hold good for everyone. So as time went from 2001 to almost till 2020, lot of studies are there and lot of major trials came that was completely against this protocol resuscitation, because many times this kind of excess fluid becomes extremely excess for a few, and some patients were inadequately resuscitated. So it was not actually a game. So surveying success, what they told is you use 30 ml per kg and you target the lactate. So this is 2012. The same statement 2016, they told instead of giving 30, they told you give at least 30. Don't give actually less than 30, but minimum 30 you have to give. In 2021 also, they told that at least 30 in first 30 hours. But the problem is this is not based on any major evidence and a lot of strong biases here. In this 30 ml per kg body weight is mainly based on observational trials. What they found is in trials with severe septic shock, well, fluids were given. They found that average amount of fluid were given between 20 to 30. So before 2012, we were giving 20 ml per kg. After that, it is changed to 30 ml per kg. It is based on observational studies rather than a randomized controlled trial. But this one number may not fit everyone. So initial sepsis guideline was telling you give fluids, optimize, get the MAP high. If you reach the target 30 ml per kg, then you start vasopressors. But what studies have found is if you don't maintain MAP quickly, longer the time you keep the MAP on lower side, and a lot of complication can happen, because a lot of kidney injury was more, liver injuries were more, and some patient had a brain tissue hyperperfusion, all those problems, because you are keeping the MAP lower, you are just keep on giving fluids. Then came the concept, you give fluids and vasopressors simultaneously. So when to start vasopressors? If you give very early before fluids, vasoconstriction become more, again it will cause a tissue hypoxia. If you give vasopressors too late, till you give 30 ml per kg fluid, and then it will be too late, again hypoperfusion will happen, lot of complications there. So major question is, if you keep on giving fluids, patient will improve to a certain extent. The response is always transient, doesn't improve blood pressure. Even though it may improve cardiac output to a certain extent, MAP increase was not consistent. So many factors were there. So it is being seen that depending upon patient, for example, you are dealing a patient with extremely low diastolic pressures, that is 44, 40, 36. It tells that very, very low diastolic pressure and a lot of vasodilatation. Better to give urgent vasopressors. Start noradrenaline very early, then keep giving fluids. That is very, very important, because just giving fluid is not going to improve, because severe vasodilated state. In a other corner, if you see that patient is decently having a MAP around 60, 64, you can give fluids, patient responds to fluids, again drops BP, again you give fluids. If that is a scenario, after a couple of fluid boluses, you add noradrenaline. So nowadays practice is to keep it both. First fluid bolus you give, parallelly you start noradrenaline, because especially in septic shock, everyone knows it's vasodilated state. So there is some kind of vasodilation will be there. By giving vasoconstrictor, you reduce the intravascular compartment. So the amount of volume requirement will be much lesser. That is the concept. So you give both. So that is very, very important concept you have to learn. So once you resuscitate a patient, then patient moves to next and the stage called optimization phase. So in this patient, if you see patient is very tachypneic, hypoxic. Now the patient is intubated and is ventilated with low tidal volume, because low tidal volume ventilation is a key for any patients in intensive care unit nowadays. Tachycardia, blood pressure decently stabilized, and the patient is having cold peripheries now. Lactate has come from 5, if you remember, it was 5.1. Now it is reduced to 3.2 with an noradrenaline of 0.6. So in this situation, patient is shifted to intensive care unit and you are seeing the patient. Now the question is, patient is decently stabilized compared to before. Now, when to give fluid more, whether this patient is going to receive more fluids or when to stop fluid or avoid fluid overload. These are two questions we have to actually answer when this patient is coming to optimization phase. So here, how does fluid is going to help? So one, it is going to improve your stroke volume because it is going to increase your end diastolic volume. So, but the problem is if stroke. So once you increase preload, stroke volume is improved by giving fluid. Patient is responding to your fluid bolus. Fluid preload will increase. There is no doubt. It's going to translate into increasing stroke volume. So that is the major question. So that is the question we are asking. If giving fluid is going to improve your cardiac output by at least 15%, then we take it granted that stroke volume increase happen. But this is not going to happen always. So increasing preload is never equal to preload responsiveness.
Just see that.
Just giving fluid preload will improve, but it won't turn into fluid responsiveness. So whenever there is a tissue hyperperfusion, then only we'll just think how to optimize this patient. Always we have to see, is there any signs of shock? Number one. Audible?
It is interrupting.
Shall I proceed?
Yeah. But there is a little lag.
There's a lag is there, Natesh. So maybe network issue.
Lag is between slides in my voice or
Breaking.
Is the voice is breaking. Voice is breaking and this lag.
okay.
Natesh, sir.
Hello.
Yes, go ahead.
Is it okay now? Shall I proceed?
Yeah.
Okay. So the first question we should ask is there any signs of shock? So that means, is there any signs of tissue hyperperfusion present or not? If yes, then you see whether the patient is going to respond to fluid, so whether he's fluid responsive or not. So to predict that, actually a lot of tests, lot of parameters are there. Like we can use IVC variability, we can use pulse pressure variation, and we can use SVC collapsibility, all those things. But by and large, if you don't use any parameter, arbitrarily if I give fluids, only 50% of patients will respond. You can see that many studies responder were around 40%, 50%, 30%, 60%. That means arbitrarily if you give fluids without using any parameters, 50% of patients only will respond. Other 50%, it's like tossing a coin. So parameters to predict fluid responses, a lot of there, like central venous pressure, POP, IVC diameter, just a diameter, all are static parameters. So they're not going to help anymore. So cardiac filling pressures by any means, whatever means I showed, it's not going to help. If you see here, R left side is the responder and NR is non-responder. So whatever the value of the central venous pressure, actually you can see that responder, non-responder is completely different. So it is not going to be helpful by using any cardiac filling pressures. So a lot of other dynamic parameters. That means you give a challenge to a cardiovascular system and see. So that's mean dynamic parameters like pulse pressure variation. We can see the 13 here is a pulse pressure variation, stroke volume variation, variability in IVC. It is not a just one diameter, inspiration, expiration variability, and probably using cardiac output monitors with a passive leg raise test. These are the common thing we use. So in our routine practice, we use pulse pressure variation more, passive leg raise test with the use of echocardiography rather than a cardiac output monitor we use. So we measure the velocity time integral. If it is the variation is more than 10% during PLR, we take it as standard patient may respond to fluids. So major problem is pulse pressure variation is extremely fantastic parameter. The only major limitation is it depends upon your intrathoracic pressure variation. So that means if your intrathoracic pressure variation is much less, then it may be falsely low. So to give one example, nowadays we use a low tidal volume in almost every patient in ICU. So using a low tidal volume, it is one of the drawback. So at least 8 ml per kg tidal volume is required to use this test. If using 8 ml per kg, then if PP is more than 12 or 13, definitely this patient is going to be fluid responsive. There is no doubt. Unless patient don't have arrhythmias, patient don't breathe spontaneously, and patient don't have a right ventricular dysfunction. So this is the algorithm. Like so many algorithms are available. You can go through it and use any of the tests that is applicable. And if the test is positive and the risk is extremely minimal, consider giving fluids. So tidal volume challenge, one of the tests actually I also was involved, and to use the pulse pressure variation even in low tidal volume. So because low tidal volume is one of the parameter, so PP was completely thrown out of. So because of that, PP were unable to use. So tidal volume, if you increase from 6 to 8 ml and see what happens to pulse pressure variation. That was the hypothesis we did. So set the tidal volume to 6 ml, increase to 8 ml, and come back to 6 ml and see your pulse pressure variation. Nowadays, pulse pressure variation present in all multi-para monitors. Just presence of arterial line is enough. No need of any cardiac output monitors. So we use that one. So when the pulse pressure variation is increased during this time, the cutoff of 3.5%, it extremely good marker to predict fluid responsiveness. So that means the rock curve was almost 99%. It was a very good marker. So nowadays we started using this more. In resource limited settings, what we use, we try to passively regulate the patient. Ideally we use a cardiac output monitor, like we use echo in our unit, and sometimes you have pulse pressure through intra-arterial blood pressure. We use that. But the problem is, if there is no change in blood pressure, that doesn't mean that cardiac output is not increasing. Cardiac output may increase, but it may not be reflected in the blood pressure. So always it's recommended to measure stroke volume. So we use echocardiography. If you have a flow track or probably a PICO, we can use, that is the best. If it's not, you can use echo. In a resource limited settings, during COVID and all, we are using pulse pressure with the passive leg rest test. So modified fluid challenge, you choose your fluid, you give in a certain time, you keep a clinical endpoint. That means I will improve MAP till 65. If a patient develops Krebs or probably increase their CVP, I will stop. This also can be used, but the problem is already you give fluids. If you give very slowly, that is not going to help. You have to give a bolus in a certain period of time. So optimization phase, the question was whether to give additional fluid or not. In stabilization, already the patient is stabilized. Now, majority of time you will not require fluids. The question changed to when to stop and avoid giving fluids. So if you see our patient at day 3, shock resolved, and patient has come out of NORAD support, blood pressure is decently okay. But here, if you see, he is continuously passing loose motion, and very large volume loose motion is following, and he is not tolerating feeds. Ileus is there, abdomen distension, so a lot of other problem is starting. So here the question is, you have to use safety parameters. So if you keep giving fluids, it may lead to a lot of other complications. So if you see the extreme right, extravascular lung water, that is extremely specific and very sensitive, and it gives you very quickly when the patient is going to land up in fluid overload. But the problem is it requires a cardiac output monitor. But without cardiac output monitor, we can't measure in terms of extravascular lung volume. That is not going to be available everywhere. Other side, if you ask for Krebs can be non-specific in ICU. It could be a part of a collapse, maybe a consolidation, maybe early pneumonia, extravasation during your active phase, may not tell it is fluid overload. So it is not going to be specific. If it is present, may give you a stimulation to think, but we commonly use lung ultrasound. If the patient is having a purely normal lungs, slowly developing a B lines, that is telling the interstitium is slowly loading with water content. That means we may not give more fluids at the point of time. But the problem is we cannot wait for B lines to appear. That's a problem. So clinically we use PF ratio. If there is some worsening in PF ratio that is not explained by pneumonia or effusion or other things, they will be very cautious. Still, if there is a central venous pressure line is there, we measure, but we won't put a line for this purpose. So third concept I'm going to give is replacement fluid. So you have to match the loss. For example, if you're having a lot of vomiting, you should give a fluid that has more chloride content. And if you're having a lot of loose motions, you should choose a fluid that replaces your bicarbonate. And if you're going to have a loss that is through kidneys like diabetes insipidus, lot of pure water, then your fluid choice should be more free water. So where is the loss? Match the loss. That is extremely important. And replacing the fluid already lost before patient has land up to you, that is very important. Because that loss amount, we don't know how much they lost. They will tell 10 times loose motions. We may not know how much they lost actually. They would have lost a small quantity or a large quantity. The fluid loss is most arbitrary. And the problem is we have to estimate some amount. So arbitrarily to replace the amount. That is very, very important. By replacing, we can slowly modify depending upon patient response. So third component is the maintenance fluids. So we finished the resuscitation, the concept of resuscitation fluids and phases, and replacement fluid, how to choose, and maintenance fluids. So maintenance fluids, the concept is to maintain your body's function daily. The goal is to prevent dehydration, to maintain electrolyte balance, to prevent generation of ketones and protein degradation. So the problem is here, if you see, to prevent dehydration electrolyte imbalance, you need water and electrolytes. So to prevent ketosis and protein degradation, you have to supplement some kind of a carbohydrate like dextrose. So that means if you are choosing a maintenance fluid, that fluid should have water with electrolytes as well as dextrose. So only usually a dextrose containing fluid with more water is always a default maintenance fluids. So as already told that maintenance fluids will have a lot of water. Idea is to replenish all compartments of your cell, like majority intracellular and interstitial and little part of your interstitium. So when to give and which fluid maintenance depends upon what is the patient. If the patient is NBM, that means not taking anything for a long time, then you can give maintenance fluid to maintain that day's requirement. Or patient is unable to take enough orally, he is on partial oral naughty. This is a situation maybe in ICU, you may find a patient who is not tolerating RT feeds completely, may require some kind of fluids to maintain, or patient is kept in view for a long time for some purpose. So all this indication will come for maintenance fluid in ICU. If the patient is on full RT feeds, we never give maintenance fluids. So these are the fluids we can choose. By default is a 0.45% DNS because we don't require a lot of sodium. We require a lesser sodium. So half DNS will have a lesser sodium, and dextrose will be 5%, and rest of things water will be there. So usually 0.45% DNS is the default fluid. How you are going to give how much? So these formulas everyone knows, 150-20 and or 4-to-1 formula. But we commonly use intra-op as well as post-op as well as in ICU 1 to 2 ml per kg per hour. This actually has been very easy to use, is been par with all formulas, but arbitrarily people use 80 to 100, 120 ml per hour for Indian weight and height. So if I choose the fluid 0.45% DNS, I have to supplement some electrolytes. Common electrolytes is potassium and magnesium. And by default, if patient is 70 to 80 kilograms, and we'll usually start with around 1 to 1.25. So 120 ml per hour is a default, we may start. If patient is completely NPO and his requirement is slightly on higher side. Because if you reduce the fluid, you may reduce the dextrose content also. So you should be a little more cautious in choosing the volume. So, but the problem is, this number cannot be arbitrarily used to everyone. For example, you're having a patient who is having a low sodium to begin with. If you give this fluid, a lot of free water is there, it will aggravate your hyponatremia. So here, instead of 0.45 DNS, I will use DNS. So that gives some sodium compartment. If the patient's potassium is already high, so that means I'll be very cautious in adding potassium. Either I may not add, depending upon potassium and readings, I will change my potassium supplements. And other important thing is patient doesn't have a urine output for past 6 hours. That means if you give a lot of volume, it may land up in a pulmonary edema, and that means patient is renal failure, very cautious. It may aggravate your hypoxia also. And this is one hypothetical balance, and we usually commonly use in our unit to give a concept of replacement fluid. If you see here in the first column and that oral compartment, first box is input, second box is output. If you see input oral compartment here, and patient is on oral diet and kanji, all those things, this forms the maintenance for the continuing a day-to-day actually activities. It will supplement carbohydrate, it will supplement some kind of electrolytes, vitamins, everything. But in our patient, if we see, patient has come with a large volume loose motions. He has passed loose motion at home itself. He has lost so many fluids at home, but how much fluid we don't know. That we have to replace arbitrarily. So that's the one we have chosen, renal lactate with potassium and magnesium 120 ml per hour. So this is going to go continuously every hour. This is the replacement for lost fluid. If you see other thing, stool output, here how we will measure this, we usually measure the diaper weight. If the patient is having loose motions, we are interested with are they passing watery motions. If they are passing semi-solid, solid, we are not at all bothered. If they are passing watery motions, we usually measure the diaper weight. And many times we are seeing the diaper weight is 1 kilograms, 3 kilograms, 2 kilograms. That means so much volume is lost. If you don't replace it, what will happen? It will become a lost fluid for next day. So again, a lot of electrolyte imbalance will happen. So what will you do if 1500 ml is there? This plus symbol indicates that the volume has come out of diaper. That means some kind of a loss already happened in the bedsheet itself. So we'll be knowing that it is more than 1500. But we can't replace all the volume. Usually I used to replace up to 50% to 75% over the next few hours. Like if you see 1500, you can just take 800 ml divided into 3 hours. 300, 300, 200 we can. Next 2 liters he has lost fluid. Then we'll add 350, 350, 350. So we'll keep on giving. This is nothing but to replace ongoing loss. Or both these things are a replacement fluid. Renal lactate only will use, so that you're actually replacing the lost potassium, lost magnesium through gastrointestinal tract. So renal lactate plus 20 milligrams KCl and 1 gram magnesium, and is the default fluid we'll give. And if the patient is taking more, we supplement with ORS also. If patient is not actually taking orally, completely intubated patient, then actually we will give through rails tube or we intravascular only. So last phase is a de-escalation phase. For example, to take our patient day 10, still patient is intubated and patient is slowly coming on CPAP and pressure support, but requiring little higher pressure support. BP normal, urine output 11 liters. It is quite high. So the question is when to start evacuation. Is it the correct time to give diuretic or whether I should wait? Or if I start giving diuretic, when should stop giving diuretic? So these questions should be addressed. So this is one meta-analysis I want to show that higher the volume, if you give, that means more positive balance, more the problem. If you see here, patient who achieved negative balance, the outcome is more favorable. How to evacuate? Some patients you have seen that they become better on their own, they will pass more urine. Spontaneous diuresis, we actually monitor the patients. Commonly, we use some kind of a furosemide, and rarely we give albumin with furosemide. If a lot of edema is there, so such patients we give albumin with furosemide to remove water. But this phase will take over almost 4 days, 5 days, 6 days. It won't happen in a couple of days. And a certain trial, they have proven that some PEEP albumin furosemide, especially done in ARDS patient, they have proven benefit. They have proved more improved hypoxia, and ventilator-free days is much more. They got extubated quickly. If the patient is on dialysis, no urine output, then we'll use during dialysis, we scuff the patient more. If the patient is having normal urea creatinine, we'll just remove water over a period of time. At least 4 or 5 liters we'll remove before being a patient to and extubation. To summarize, and renal lactate is the choice of crystalloid. 4 to 5% albumin. If you want to use colloids, you can use. You should know why are you giving fluids, whether because of hypotension or need of vasopressor or lactate is high. Why are you giving? That is important. Always use some parameter. Use pulse pressure variation. If tidal volume is low, use tidal volume challenge. If you don't have all these things, you can use Ivc variability or at least simple PLR with blood pressure. At least something you use rather than using anything at all. What to monitor? So why are you giving fluids? Same thing you monitor. Because of hypotension, monitor blood pressure. Lactates, monitor lactate. If it's urine output, monitor urine output, and obviously other parameters as well. So one major thing is if the patient is having a higher FIO2 requirement, don't pump more fluids. Very guardedly give fluids while resuscitating. And if already giving a good volume, then don't be reflexively giving more and more because patient is responding. Because that patient could be a very transient responder. He will respond to a few minutes, again he will drop his blood pressure. So maintain BP with non-adrenaline. and the patient responded last time, short response. So that means you know that this patient is going to leak out more. So don't give more fluids. So these are things you should keep in mind. So hypothetical scenario, I want to just give it and conclude quickly. So this is the patient I gave, AML patient who came with hypotension, peripheries are cold, and acidosis, predominantly a metabolic, high lactates. So here the prime thing is he's having hypotension that is severe enough and very cold peripheries and acidosis. So the prime goal is to resuscitate this patient. If you want to resuscitate, that means I have to use a fluid that stays in the intravascular compartment, and I'm not going to use colloids anymore. First choice always crystalloids, and going to use vasopressor along. The patient will be in intensive care unit. If the same patient, I'm just giving a scenario, he came with only acute GE, no major sepsis. He came with ER with normal blood pressure, but peripheries are warm and high lactate. So these patients either will be monitored in the emergency itself or probably admitted into high dependency unit. May not be first reflexly in ICU. Such patients, actually, there is no urgency to resuscitate. So here the goal is to replace whatever the fluid is lost at home. That means he has come with loose motions. Obviously, my choice will be renal lactate. Lactate will be converted into bicarbonate in the liver. That will be supplement more bicarbonate. Along with electrolytes, this guy is not going to eat more. That means I have to add maintenance for the day. If he's eating more, well and good. If he's not eating, then I have to choose a maintenance fluid for this patients. Simple patient, just a few episodes, clinically stable. It doesn't come to actually hospital. Patient is immunocompromised, usually is instructed to come to hospital so that they won't miss the early sepsis. Such patient comes, he is stable. That means he just require replacement. We'll give only ORS. We'll send him home if he is stable. So depending upon clinical scenario, the choice of fluid differs. What phase is coming, how actually is coming. So final take-home message will be fluid therapy in ICU. What is your goal? Are you going to resuscitate a patient, or just going to replace, or you're going to give maintenance fluid? Fluid needs are not static always. You have to reassess the patient. Depending upon patient progress, what phase he is on, accordingly you have to choose. Always look for complications. So fluid choice in ICU for volume resuscitation, choose renal lactate as a crystalloid. Plasma-lite can be used, nothing harm, but it's very costly. Normal saline is well and good, parallel to almost all crystalloids. Colloid, if you want to use, especially in a high volume resuscitation, please use albumin. Don't use any starch. Thank you very much for listening.
Thank you, sir.
That was an excellent talk, Dr. Natesh. Though there was a, voice lag, I think your slides conveyed the message what it's supposed to. So I'll open the platform for discussion. Over to Ravi sir, Gurudat sir, Gangadhar sir, if he's there. Shikumar sir.
Hello.
Yes, sir. Yes, sir. Go ahead.
It's a good presentation, wonderful presentation. Your SALT ED trial is, I think, is one of the landmark trial, I feel. Natesh, can you hear me? Hello.
The first trial was split trial, sir. It's the same Australian, New Zealand population. That was more in emergency. SALT ED, they give fluids in EMED, they continued in ward, and few were only ICU patients. That was more pragmatic trial because only one fluid was not chosen. So they actually give balanced crystalloid to the EMED. They allowed to use other crystalloids also during their ward. That was more pragmatic. So that didn't show much mortality difference. Only AKA, actually, there was some difference was there.
Yeah, since the initial amount of resuscitation fluid can be given 1 to 1.5 liter of normal saline, and the rest you can continue as a renal lactate, I feel, in that SALT ED trial. So that is conclusive, one of the landmark trial, I feel. Then your Christmas trial and the chest trial. These are all small trials and crystalloids. Then the Scandinavian. Scandinavian is one of the landmark trial also. It's done in a huge patients. Huge around 7,000 to 8,000 patients has been worked out in the Scandinavian trial. So I feel, and the other thing is, how far normal saline can be given in the initial period. Can it be 1 liter, 2 liter? I feel 1.5 liter would be enough to sufficient to reduce the chloride level in the blood, which affects the kidney. Hello? Hello?
Dr. Natesh,
Yes,
can
sir.
you hear?
Actually, the normal saline has been used for almost more than many decades. And
Yeah.
only for last 1.5 decades, there is a debate whether to go for it. And one logical answer could be, and if you are using, yes, I can hear, sir.
Yeah. Hello?
So, am I audible now, sir?
Yeah,
Yes,
please,
yes,
please.
go ahead.
Yes. If you are choosing normal saline initially, and if you are measuring the chloride levels, for example, now the chloride is 98. So after 1 liter, it is 103. Still, patient is hypotensive. We give more normal saline, and the chloride is 106. That means we are seeing a trend that chloride is increasing. If that is the case, then probably we can switch the fluid before itself to ringer lactate. Or patient is having a traumatic brain injury, or may have a large stroke before, or a patient is having unconscious. We don't know the cause, and patient has hypotension. Such cases, we can start with normal saline, and we can monitor the patient's GCS. We can get more information. If the chloride is not increasing, then we can still continue using normal saline. So we can take a logical decision rather than more evidence based, because evidence will keep changing. Recently, few months before, when basics trial came, that was against normal saline versus balanced slides from Australia. They found no difference between any outcome. No outcome difference, no secondary outcome. Secondary outcome means no ventilator-free days, no organ dysfunction, no kidney injury, nothing. So almost equal. So normal saline almost less than 20 rupees, and commonly practicing in all government settings, including we use normal saline as a first choice. Because first 1 hour, we may not rule out all TBAs, we may not rule out everything. Once patient becomes more, we automatically switch to ringer lactate by default. That becomes much safer. So once TBA is ruled out, we use ringer lactate to almost everyone.
Okay. But the SID also comes down. Right? SID is almost 0 in normal saline, whereas in acetate it will be around 40, 48. So where metabolic acidosis will be very high in that.
Yes, sir. That's why better not to actually use normal saline, like how you gave one value 1 to 1.5.
Yeah. And another question is mine is.
So almost that is a decent number. But usually when it comes to ICU in emergency,
I know. Another important question is, see, you all use this SVV, PPV in a control mode ventilation, on ventilator. Any other modes that you can monitor in the spontaneous ventilation patient with the shock, except PLR. PLR can do it, but he needs an advanced monitoring also. Any other monitors can we use apart from with a spontaneous patient who is in spontaneous breathing, who is in shock, something like that, is in sepsis.
So in PLR, sir, actually, there is one good trial that is specific for resource limited settings, where they compared using the capillary refilling time. So what they did is they measured the capillary refilling time. To give example, if it is 8 seconds, then they did PLR. If it is reduced to 5 seconds, so that means the cardiac output is improving. So that trial has shown that if you use capillary refilling time, decently good parameter. But the problem is, if the patient is in ICU in a cold environment, that can be a little altered. So initial periods where we don't have anything, so IVC variability, if patient is not hardly breathing, very peacefully breathing, we can use. But majority out of 10 patients, only 2-3 will peacefully breathe. Other people will be more tachypnea because of shock. So IVC is not a first choice. And usually such kind of a scenario, and we give fluid, and because we'll give some 200 ml over 1 or 2 minutes, we'll just see how the blood pressure changes. We'll measure the velocity time integral through echocardiography. If there is immediate changes there, then we'll give some more. So guarded mini fluid challenges we use in spontaneous breathing patients. And obviously PLR, if we use all these things after 6 hours, first 6, because obviously they may have some kind of fluid responsiveness by default. Once you cross 6 hours, we know such patients we use either PLR with echocardiography, or intubated patient means we use other parameters I mentioned.
Yeah, intubated is not an issue, but all the everywhere you don't get a volume or flow track. So we'll have to have some clinical assessment. Like you said, the capillary filling pressure would be fine.
I think mini bolus can also be applied. Mini bolus can be.
Hello.
I think Natesh's voice again we are losing.
I know.
Yeah, I'm there, sir.
Oh, okay.
Like minute challenge, I told it can be used 200 ml, but we have to use some parameter to make sure your cardiac output is increasing. So we use echocardiography, and anyway, cardiac output monitor will be used when a patient is a little long term. Usually, patient who recovers quickly, they will recover without any additional monitoring. Usually, who remains hypotension on noradrenaline support day 2, day 3, day 4. That is the time we'll think of going for advanced monitoring. So out of 10 patients, only 2-3 will be such sick, and majority of times 5-6 patients out of 10 will improve within 1 or 2 days time.
Natesh, one last question from me. When you start vasopressin, you started noradrenaline.
Yeah, something is going on. I don't know what is wrong with this. I can't help you.
So there are two quick situations, sir. One, for example, if the patient is having extremely low diastolic pressures, like for example, diastolic pressure is 40, 41, 38, that tells that he is severely vasodilated. Such patient usually we will add vasopressin along with NORAD. Second scenario is you give noradrenaline, stabilize the patient. Still, patient is requiring higher NORAD support after adding idocot not coming down and still having some 15 ml or 10 ml plus NORAD. Such time we'll add vasopressin, sir.
Okay. So that's right. Because exhaustion of the receptors will be there. We thought around, we usually start around, say, when 3 microgram per kg per minute is an noradrenaline exhaustion, then we don't go usually diastolic. So when 3 microgram per kg per minute, at the end of that, we can start vasopressin. There's some average value we take. Okay. Thank you, Nikhil. Thank you very much.
Natesh, there is one question, if you're able to hear me, from Dr. Rajni. We can use both RL and normal saline alternative instead of only one type to get benefited by both types. Any study using both, sir? RL as well as normal saline?
So that's the thing. Actually, we have a lot of crystalloids for resuscitation, like including a plasma light nowadays. So the question is, whichever crystalloid you use, it is going to behave almost like any crystalloid. Like it is only 1/3 is going to stay in your vascular compartment. So if you are requiring more crystalloids, for example, already you are giving 2 liters, still you are pumping more and more fluids. Already your cumulative balance reached up to 4-5 liters. Then still patient is fluid responsive, risk is less, then we may add some albumin. But only problem is albumin, the cost is very high. So in this scenario, in Indian setting, we still give crystalloids. Such scenario, we keep Ringal lactate only. Because actually by normal saline is by default is chosen in emergency as per our hospital protocol, because we can't roll out everything in first hour. So they usually give a normal saline at least 1 to 1.5 liters in emergency medicine only. They'll usually commit noradrenaline support to ICU. Such scenario, we use Ringal lactate. If the patient is still having altered sensorium, so and so, we still give normal saline. So like how actually she has pointed out, we combine RL and normal saline. But when the volume resuscitation goes high, I still think of colloid. But if I think of colloid 10 times, I have given only 2 times.
Okay. Thank you, Dr. Natesh. Thank you. I think that clears Dr. Rajni's doubt, I guess. Gurudat sir, anything from your point of view?
Yeah, Dr. Natesh, excellent lecture from you. Even after so many, years of a lot of research work that has been done, still we do not know exactly what kind of fluids to be given, how much fluid to give. Still a lot of confusions still there. Of late, we are hearing about personalized goal-directed fluid therapy. So you have to personalize for that particular patient and probably use the Frank-Starling curve, as you also had showed that Frank-Starling curve, and whether the patient is fluid responsive or not. So definitely that can be used. And one thing about, majority of the times you are talking about the invasive monitoring and, the dynamic parameters using invasive monitoring. So can we also use pleth variability index, which is a non-invasive monitor? And probably even in smaller institution also, one can go for pleth variability index to know whether the patient is fluid responsive or not. So any comments on that, Natesh?
Thank you very much, sir, for your comments as well as the bringing in the interesting question. Pleth variability index, definitely, sir, it is actually coming up in a big way. The reason is because it is non-invasive. It can be used in any patients. You intubate, non-intubate. But the only problem is pleth variability is again depending upon your heart-lung interaction. If the patient is not ventilated, so his breathing will change from one breath to next breath. He will take 400 tidal volume. Next time, he will take 500. So that change will cause some kind of a thoracic pressure change that will automatically give a different pulse variation. So that's why it still is not very practical in spontaneous patients. Definitely, yes, in intubated patients, and especially very, very helpful in intraoperative patients, because such patients may not be having a profound shock always, but still they may be having a lot of fluid deficits in the complex surgeries and immediate post-operative period. So it is coming in a big way. But in ICU setting, who is on non-adrenaline support, sometimes the pleth variability may not be picked up correctly. So false values are keep coming. That's why in ICU with a shock, it is not coming in a big way. But definitely patient having a shock with very, very minimal vasopressors, and especially perioperative period, it is going to come in a big way. And a lot of multipara monitors, they will bring up in the monitor itself to give a PA index. Nowadays, even the portable pulse ox also is giving PA index, but it's not fully validated. We also actually use that during COVID time. So in some patients, we found it a little more useful. But the only thing is, if you get a graph, we rely. If you don't get, we don't rely. But definitely, it is going to come in a big way. Thank you, sir, bring up the interesting point.
Yeah, thank you so much. And one more fluid you did not touch upon is hypertonic saline. Any role of hypertonic saline in any condition of critically ill patients?
Yes, sir. Actually, I purposely didn't touch so that the students won't get actually confused. Because it is not come under resuscitative fluids. It is given for some other purpose. But one good point is that if you give 3% saline for any purpose, it may actually expand your intravascular volume also. That actually they should have that concept. So when you are giving hyponatremia corrections, and the patient is actually coming with a hypovolemic hyponatremia, that means with a lot of vomiting, loose motions, they have very low sodium. In such patients, usually we give 3% saline to tide over crisis to reduce the cerebral edema. So in that scenario, some patient will be parallelly on ringalactate and normal saline resuscitations. Once your volume status picked up, the sodium change will be very, very drastic. Quickly, they will mount sodium from 120 to suddenly 135. Because actually your stimulus is lost now, your volume compartment is resuscitated. Such cases, rather than giving a larger 3% saline, we actually restricted to lesser volume of 3% saline, because there is an ongoing resuscitation with ringalactate or normal routine normal saline parallelly. So such cases, if we're actually not giving that one, then probably decent amount of 3% saline we can give in such population only. So I won't encourage, because resident used to take it and they give large boluses. It lands up in a higher volume because it gives a higher volume expansion. Quickly, it will improve the hypovolemia in such scenario, and sudden shoot up of sodium will happen. So actually in our unit, we restricted to give only 20 ml per hour unless warranted to increase more.
And the other thing is, we used to talk a lot about glycocalyx and the destruction of glycocalyx in all these patients with sepsis or any inflammatory conditions. So anything about glycocalyx and fluid therapy?
Yes, sir, definitely. In one of my slides, I showed when you are giving colloid actually improves the intravascular volume. But in case of severe sepsis or SIRS, even take as a polytrauma, there will be a breakage of membrane will happen. The glycocalyx will be damaged. So a lot of leaky capillaries will happen. So that will lead to seepage of vascular volume into the interstitium, causing more edema and causing more harm. So the glycocalyx damage is because of inherent disease like sepsis he is having. So controlling sepsis will turn away all these things, and all this fluid again will come inside once the sepsis is recovered. So glycocalyx even though it is very good to understand, so we don't have any major parameter to measure. Like,
Yes.
for example, you measure parameter tells the damage is very high. So all are still experimental stage, but it is good to actually know the concept behind how the glycolysis gets damaged. So it gives more understanding to choose fluid and understand how the fluids come back to the compartment. Initially, we thought it is because of a pre-capillary and post-capillary. Nowadays, the after glycolysis, it is more of a lymphatic that brings the fluid back rather than it's a post-capillary.
Correct. So anything about SIADH problems? Especially we talk a lot in the post-operative period of critically ill patients. Syndrome of inappropriate ADH secretion, hyponatremia, the problems, especially in critically ill patients posted for surgery in the post-op period.
Yes, sir. Definitely, sir. The post-operative is a very challenging, sir, because actually one of the things we usually rule out is volume status. If volume status is actually low or high, we won't think of SIADH. If we couldn't judge whether it is near normal or slightly high, then that is the time we just think of SIADH. And if it is not severe during perioperative period, we just monitor. We won't do anything because the stress of surgery usually settles down in 48 hours time. Automatically sodium will go up. So in such scenario, usually we tell them not to give more normal saline, better to give ringal lactate, because if you give more normal saline, again problem will happen. Usually the physiology is going to turn around quickly, and even a small analgesia giving, you will reduce the SIADH if it is because of pain only. So many factors will play a perioperative period. So usually we won't target it. So if it, unless severe hyponatremia, then we'll see into the intra-op records what kind of fluids they are given. So have they given any more free water? Because a lot of JA surgery they give wash. So instead of normal saline, if they are given any 5% dextrose, some wrongly they are given. All these things will go through, and especially during urologic surgeries in TERP and all, it's more common SIADH. So differentiating in the first 24 hours will give us a time, because the insult is almost not there. Automatically they will improve their sodium. Such scenario, instead of 0.45 DNS, we give DNS.
So another lot of confusion is for renal transplant patients between normal saline and ringer lactate. Because what they have found is when we usually use normal saline here, because the nephrologist says that normal saline is the ideal fluid, but actually the potassium levels will go up because of the metabolic acidosis. Normal saline is going to produce hyperchloremic metabolic acidosis. But many other studies also have shown that ringer lactate, though it contains potassium, it may not increase so much of potassium for these patients intraoperatively and also postoperatively. So what about this confusion, Natesh?
Exactly correct, sir. So ringer lactate in 1 liter, it will have 5 milliequivalents. So usually we'll tell that, for example, if potassium has to go high in a blood, that means the kidney is not working. So if kidney is a normal state, whatever potassium you give, kidney will throw it out. Unless you give in a rapid fire, like you give so high load of potassium immediately, it will immediately go up. If you're giving slowly, if it is excess, kidney will throw out. Especially in a kidney transplant patients, usually they'll be requiring dialysis for initial few days time. And giving a high chloride will stimulate the RAS system, because chloride is one of the things that acts on medulla densa. So if you give more chloride, it will feel that volume status is normal. Someday it may give falsely hope that high chloride is reaching medulla densa and your volume status is good. So that confusion may happen physiologically. And transplanted kidney don't have a sympathetic nerves, so that also is not there. So in such scenario, still we actually use ringer lactate, and because there is no major evidence, so probably every alternate fluid normal saline is still being given. So there is no major rationale. It is morely because of our own experience and the way the department is developed over a period of years that is being practiced. Because we actually know both of them is not going to cause major harm unless given a large volume. So we cautious more of a volume rather than type of fluid here.
Thank you, Dr. Natesh. Thank you so much.
Thank you, sir. We'll move on to next topic.
Yes, sir. Thank you, Natesh.
Thank you. And
Excellent.
thank you everyone for giving me this opportunity. Thank you all.
Thank you, Dr. Natesh. Wonderful talk. Okay.
Thank you very much.
So Shikumar sir, we'll move to the next one.
Yeah. Please go ahead, sir.
Right. So next we have a wonderful topic now, acid-base analysis, that is arterial blood gas by Dr. Sumalata. She is a consultant and head of the Department Critical Care Medicine at Suyog Hospital, Mysore, India. Her special interest being mechanical ventilation, critical care, nephrology, immunology, and infectious diseases. She has quite of publications on her name. And thank you, madam, for joining this and accepting our invitation. And over to you without wasting your time. Thank you so much.
Thank you, everyone. I feel a lot of nostalgia because coming back to all those speaking in front of all our teachers. Ravi sir may not remember me, but I was his MBBS student. And Gurdat sir is my HOD and an inspiration to me. He will remain a lifelong inspiration. And then Manjunath sir, again, he's been a source of constant support. So in front of all the stalwarts, giving this talk means a lot. So we already said, so I'll not waste much time. I prepared this thinking that we'll have more students. Considering that we have stalwarts, you may get bored. I'll try to make it more interesting. Sorry about that. So arterial blood gas analysis per se has become a routine monitoring in ICU. Why? Because it reflects the biochemical status of the patient. Although clinical examination remains the mainstay, history taking and clinical examination is extremely important, but mere history and clinical examination has some limitation. It cannot tell whether the patient is producing ketoacidosis, lactic acidosis, what is the pH, what is the carbon dioxide, whether he's having alone hypoventilation or there's a shunt mechanism. All of this cannot be made out completely clinically. And most of the times there is a mix of disorders that happens, especially in critically ill patients. By the day 3, day 4, most of the critically ill patients have mixed acid-base disorders, which is very difficult to make out clinically. It may not be possible at all. So ABG analysis has become a mainstay, and it is become a routine monitoring device. ABG BD, ABG, ATARLI, all this has become a routine monitoring device to anticipate patients' deterioration. So in my talk, the outline will be, first we have to understand the fundamentals of oxygenation and ventilation and concept of acid-base handling by the buffer-base system. If we know this, the rest of the concept is just, memorizing a few steps and just recalling. I am somebody who is not so pedantic, so I would not go into the numbers and details. I would rather understand the concept. So I would stress upon the concept more than the steps exactly, and the steps we'll learn on the go while solving the ABG. Although I'm focusing on Boston approach, thinking that the students will benefit from the most common approach, that is the Boston approach. It is not the most robust. There are other approaches. Stewart approach is more robust. And Copenhagen, with a lot of debate, now settled that not so good approach, especially useful only in trauma patients. So first we need to know where are the acids coming from. Okay, in healthy individuals, if there is complete metabolism of your carbohydrates, proteins, and fats, there aren't much acids developed. Okay, so that the only in certain scenarios you'll get acid development. That is when you have amino acids, cationic, lysine and arginine, and cysteine and methionine, which are the sulfur-containing amino acids. If there is complete metabolism of carbohydrate, fat, and because all these produce neutral end products, that is nothing but your water and carbon dioxide. Whereas in disease process, we are in trouble because there is intermediate, these intermediates of carbohydrate and fat metabolisms are your lactates and ketones. So they are produced in large quantity, especially when there is a tissue hypoxemia. And externally added acids like in intoxication, methanol, ethyl alcohol, ethylene alcohol, toluene, salicylate, all these poisonings, you have an externally added acid. So the acid load is increased when there is excess loss of bicarbonate, because that's the one that maintains the electrochemical neutrality. So loss of bicarbonate can be again in gastrointestinal or renal. We'll go into the detail in the further slides. So we should have a bird's eye view. If patient is healthy, the acid generation should be very less. If the acid generation is high, that means that there is some undergoing disease process, either an externally added acid or endogenously produced intermediates of metabolism of carbon dioxide, fat, and protein, or there is an excessive loss of bicarbonate. So the mnemonic for this is mud piles. We'll discuss about it later. So how are the acids handled by the...
Your screen is not visible. Slides.
No, it's visible, sir.
Yeah, visible.
Visible, sir.
How are these acids handled by the body? Mainly, it is the lungs and the kidneys which...
Visible, okay. Go ahead.
Am I audible? Are there any...
No, you're audible. I'm not sure why the slides...
No, I can't see that. Okay, that's fine. Go ahead, madam.
So, how are these acids handled once they are produced in the tissues? So, the main excretion is by the lungs and the kidneys, but the buffer system is the one that prevents these acids binding to the proteins. This is the entire concept of having buffer system and lungs and kidneys excreting is this. Once these acids, the H+ ions bind to protein, there will be irreversible change in their configuration. The proteins cannot act. Most of the proteins are enzymes, and then it goes to a point that ATP is not synthesized and we will have trouble. So to prevent all of this, you have the intermediates that are your buffers, and the final excretion is by the lungs in terms of carbon dioxide, and renal excretion is mainly by the ammonium ions. So acid balance, daily acid balances because of your dietary intake or whatever discussed in the previous slides, then the H+ ions generated by it will be buffered by the bicarbonate buffers or whatever buffers that's there. Intracellularly, it is the phosphorus, and intravascularly, hemoglobin. So, and this bicarbonate is regained by excretion of ammonium ions in the urine. That will be, I'll tell that in detail when how the kidneys compensate. So this was only about acids. What about the base? See, typical non-vegetarian diet, the most commonly you have very high amount of sulfur containing amino acids. So what you eat is you eat a lot of acids, whereas base inputs is high in a vegetarian diet because the base input comes from your dietary fruits and vegetables. So apart from this is the main intake in healthy individuals, whereas in disease, there are a lot of base inputs in terms of villus adenoma, use of diuretics, where volume contraction causes additional base absorption, gastric suctioning, where you lose H+ ions acid, vomiting, milk alkali syndrome, and some congenital diseases along with renal diseases like Liddle's, Barter's, and Gitelman's. These are where you have excess bases. How does the base balance happen? Base balance is not as simple as acid. It's actually a two-step process. The moment the dietary excess base intake is there, this base is now converted to citrate ions by the liver, and this is excreted in as organic anions in the urine. So one might simply question, why can't the acids and the bases combine, form salts, and these are excreted in urine? Why this cannot happen? Why? Because mainly you should have a normal urinary pH of 6, because excess acids and base combining salts will precipitate in blood, and the kidney tubules also it can precipitate, and this will lead to formation of uric acid stones or a calcium phosphate stones, which will cause renal damage. So considering all of this, the acid should be dealt separately, the bases should be dealt separately. So the body has a separate mechanism of handling acids and bases. So what are buffers and why do we need buffers? Buffers are any chemical which has a combination of an acid part and a base part, and it can combine with any strong acid or a base to form a weaker acid or a base to prevent any change in intra-arterial pH. So you should have this is the acid part and the base part, and the overall pH will be dependent on its pKa, and this is the log equation of our well-known Henderson-Hasselbalch equation. So there are two types of buffers, that is bicarbonate and non-bicarbonate buffers. The concentration, of course, will be on bicarbonate buffers. So why we concentrate more on bicarbonate buffers? A, it's the largest buffer that's available in the body. Two, it is easy to measure, and it's an open-ended buffer system. That means where the end products are excreted by both lungs and kidneys. So not only your carbon dioxide is excreted by lungs, your bicarbonate is the end products that are excreted by the kidneys. So it is a kind of a central buffer which has connections to everything. And measuring this, the assumption is, especially in Boston approach, which I'm going to tell later, that this buffer is in equilibrium with your phosphate and your hemoglobin or other protein buffers. And measuring this will reflect the overall buffer-based system. So that is what, because it's the largest, so that's how the bicarbonate buffers become important. But the most important thing in this Henderson-Hasselbalch equation is, remember the buffer system to be good, especially we produce a lot of acids, that acid buffer system should be converted to carbonic acid and should be excreted to through lungs via excretion of carbon dioxide. This happens only if the equilibrium formation equation can shift to left, in the sense that the blood should have low PaCO2. The moment your carbon dioxide is high, the buffer system becomes grossly inadequate and inefficient, because this forming carbonic acid, then breaking into carbon dioxide and water cannot happen, because there is now shift to right side towards this. So that's why the concept is, it's not the ABG that's important, especially in terms of shock, to understand how is the tissue perfusion, or even VBG is more important, especially the mixed venous, the brachial venous carbon dioxide levels or the pH, because that's where the tissue level pH you understand. So that is why the whole bicarbonate system collapses the moment your CO2 is very high. So this concept has to be really understood, because the equation cannot shift to the left side. So even though the arterial pH may be on the higher side, the venous pH goes on decreasing at the tissue level, because the carbon dioxide elimination is not happening. So since carbon dioxide, that is carbonic acid production and elimination, is directly proportional to your PaCO2 level, the highest influence on acid-base balance is by lungs. So and PaCO2 reflects the carbonic acid production extremely well. So you can rewrite the equation by removing the logarithm here, and pKa of this buffer is 24. So you will get this equation that H plus is equal to 24 into PaCO2 by bicarbonate. This is an important equation, because your ABG machine does not measure bicarbonate by any electrodes. It calculates bicarbonate by this formula. So if you think there is any problem with your ABG machine, you are checking validity, you are putting back this whatever the measured bicarbonate in this, and then there is a corresponding chart for the pH and see whether it is correct. So basically, when you are checking validity of an ABG, you are checking whether the math done by your ABG machine is correct or not. So there are other non-bicarbonate buffers. As I told, it is the intracellular buffers that are very important. Those are nothing but your proteins and phosphates, and hemoglobin is the predominant buffer inside the blood, and phosphate buffer is in fact more effective. As I told you in this equation, so buffer is really effective. Its pKa is equal to pH. This happens when there is equal component of acid and its base component. But pKa of bicarbonate is 6.1, whereas blood pH is 7.4. So it's not that good of a buffer. Whereas phosphorus, it is near almost 7.1, 7.2. So it's actually phosphate buffer is a better buffer than bicarbonate buffer. But since the quantity of phosphate buffer is less, and it has become a practice to measure via the bicarbonate buffer. And all non-bicarbonate buffers are closed system. The end products remain in the system after the buffering, and they're not excreted by lungs completely. So that's why they don't assume that much of predominance, and it's compared to a bicarbonate buffer. So this is extremely important, the renal compensation, because most of your bicarbonate is filtered by your glomerular filtration rate. 100% bicarbonates are filtered. If we lose that, we'll become very acidotic. So 19% of the filtered bicarbonate is reabsorbed in PCT by 3-stage process. That is extremely important, by sodium hydrogen and hydrogen exchanger at your PCT, and then you have carbonic anhydrase 4, which converts your hydrogen ions, breaks down your carbon dioxide and water into hydrogen and bicarbonate ions. This gets transferred intracellularly, and then you have carbonic anhydrase 2, which then again combines your H+ ions, which is exchanged into bicarbonate, and that is regenerated and then brought back to the blood. And this is how you regain the filtered bicarbonate. So this is extremely important. If this mechanism fails, this is where you get a proximal RTA. Proximal RTA is again 3 types. Just for the interest, I'm telling, it can be just pure proximal RTA without Fanconi syndrome. That means it may not be associated with albuminuria and glycosuria and all, amino aciduria, sorry. And whereas it can be associated with distal RTA, pure without a pure proximal RTA component. Whereas the other components parties, as I said, it can convert base to its salt, in the sense how it helps in conversion of base to its salt. The citrate anions, as I said, base handling by the body. The citrate anions are then excreted through, organic anions are excreted through kidney. So when you eat a fruit or vegetable, this is how your bases are excreted. And most importantly, it maintains a good urinary pH. This is extremely important. If urine pH normally should be 6, okay, this is where the kidneys function very well. The moment you have pH dropping to 5.5, 5.6, your uric acid stone, so that's also weak acid, it precipitates. Whereas if you excrete excess bases, your calcium phosphorus stones precipitate. This is very important a concept, because especially when you're giving soda bicarb to a CKD patient, what happens is CKD patient can have a low, it usually have ion gap metabolic acidosis, mainly because of low GFR, and so the bicarb filtered is also less, and they have a metabolic acidosis. Now, if you give soda bicarb to them, they have and volume, what happens is there is a bicarbonate urea. Once there is a bicarbonate urea, that means bicarbonate is excessively secreted in urine. What happens is your calcium stones precipitate, calcium phosphorus. So you should be extremely careful in giving soda bicarb long term, especially all this Savalmer also has the same pathophysiology, because they can precipitate your calcium phosphate stones. So apart from the kidney, the main acid-base handler is your lung. This is because it has the highest control over your carbon dioxide elimination. Almost, I think 15,000 millimoles of carbon dioxide is produced, and it is direct. The elimination is directly proportional to alveolar ventilation, and it is reflected very well by your PaCO2. So it's a linear equation. So the moment you know the PaCO2 status of the patient, you know the alveolar ventilation. So any PaCO2 more than 45 suggestive of hypoventilation, whereas less than 35 suggestive of hyperventilation. So these are all the causes of acute and chronic hypercapnia. I was just refreshing most of the things: neuromuscular and central and respiratory, drive, depression, and all these things. Just keeping this in mind, I would like to stress on this. The other causes: circulatory shock and sepsis. This is one thing that especially students need to keep in mind. The rising PaCO2 in a patient who is dying, he's on DO inotropes, NORAD is there, vasopressin is there. Still, PaCO2 is high. So when I was a student, I would increase the respiratory rate, thinking that it is mainly because of inadequate alveolar ventilation. That concept has to go, because in circulatory shock, there is so much of dead space in terms of poor tissue hypoperfusion, that the generated carbon dioxide at the tissue level, the muscle level, is never brought to the lungs to be excreted. So you increasing respiratory rate, thinking that or rise in CO2 in a dying patient, the pH is 6.9, PaCO2 is like 60, 70. Your nephrologist comes and says, no, you are not ventilating enough. Or your cardiologist comes and say the ventilation, this is purely because of hyperventilation. This is wrong. This can be because of your pure dead space problem, in terms of dead space, meaning that the blood circulation is not enough to carry on the carbon dioxide that is produced from the peripheries back to central circulation, and then exchange happening and then excreting in lungs. This has to be kept in mind, that in a terminally ill patient or a very bad septic shock, PaCO2 can rise despite having adequate alveolar ventilation. So interpretation of ABG, this is the core concept of the talk. So once understanding all this, I think the rest of this process will be very just purely mathematical. And there are three main methods. Fenkel-Stewart is actually more robust. It explains, it takes into account the other component, not just your bicarbonate-centered approach where you only think of bicarbonates. Here the albumin effect, the phosphorus effect. It can also explain other phenomena like acidemia when you infuse normal saline, and why alkalizing effect is there when there is a hypophosphatemia or hypoalbuminemia. All this are explained by Fenkel-Stewart, but it is too cumbersome and too tedious, and it may be too much for students. So that's why the most commonly used is Boston method, and I'll stick to that. Copenhagen method was at one point of time competing with Boston, and there was a great transatlantic debate, because Boston was by Tufts University, Copenhagen by European, and they said ours is better. So that the transatlantic debate was there, but now the debate has settled. Copenhagen is not much reliable. It will be really good in trauma patients, and most of them are now sticking to Boston approach. So despite all of this, the studies have not shown any clinical benefit in terms of using Fenkel-Stewart approach at the bedside. So finally, whatever method you use, as a clinician, you need to use all those tools, assimilate, see the ventilatory parameters, see the clinical history, and come to a correct diagnosis at the bedside to improve outcomes. So using Fenkel, Boston, or Copenhagen doesn't really change the outcome. Whichever method you use, you have to usually apply it at the bedside to arrive at the correct diagnosis. So I have already told it is a bicarbonate-centered approach. So it was developed at Tufts University, Boston. See, this is most important. It was done in healthy volunteers, pregnant women, smokers, and sick patients with metabolic acid disorders. And they developed 6 equations, and they categorized into 6 primary disorders. That's why I think maybe the metabolic alkalosis equation is the least reliable and most variable of it. So these are all the 6 equations. It's just I would like to remember as first I'll remember in my brain as respidosis, respiratory acidosis, and acute and chronic. With every rise in 10 millimeter of PaCO2, you will have 1 and 4 in terms of acute and chronic respiratory, whereas metabolic it is 2 and 5. So respiratory alkalosis. And metabolic acidosis, we have Winter's formula, that is 1.5 times the measured bicarbonate plus 8 plus or minus 2. And metabolic alkalosis, as I told, is most variable. There is at least 0.5 mm increase in 1 PaCO2 every 1 increase in bicarbonate level. So apart from this, there is a change in pH with every change in CO2. That is 10 millimeter rise will, if it is an acute disorder, the pH drops by 0.03. If it is chronic, 0.08. So these are all the basic steps. First, you have to check the validity of the patient and patient details, and oxygenation status and ventilation status should be checked simultaneously. And the major step is the determining which is the primary disorder by seeing the pH, PCO2, and bicarbonate, and you see the compensated response. The anion gap and the delta gap or the delta-delta ratio, all this was an extension to Boston approach. So finally, you have to see all this and see which signs fits better. Let's just not become pedantic and let's go to case discussion. This is a 60-year-old man who was admitted with gluteal abscess. He's a known diabetic and he was on oral hypoglycemic agents. His oral intake has been reduced since the last 2 days and he has now breathing difficulty. His blood pressure is low. He was resuscitated with intravenous fluids, after which it was normalized, the BP, and he was started on 6 liters of oxygen on face mask, and ABG is done in wards. So the question is, what is the cause of breathing difficulty and what is the acid-base disturbance? This is the ABG. So pH is less than 7.4. So there is an acidemia. There's a difference between acidemia and acidosis. Acidosis is the process that is happening in the body, acidosis or alkalosis, where acidemia or alkalemia means the pH is changed. So this is an acidemia. You may have metabolic acidosis, metabolic alkalosis, but still have a normal pH or no acidemia or alkalemia. So that needs to be very clear. So this is because that's the common thing that we see in IC. The pH may be normal, but there will be no acidemia or alkalemia, but the patient will be having a mixed disorder having both alkalosis and acidosis. So this pH is acidemic. And PCO2 is grossly low. So roughly for the calculation purpose, from 40, you can think that it has dropped to 20. So to 20, half, and bicarbonate is 9. So there is a bicarbonate is also low. So sodium appears normal, 135 to 45, and potassium normal, chloride mildly elevated, and lactate is 4.2. For the easier purpose, anion gap is 17 and PaCO2 is 56. So these are all the normal parameters just for the reference purpose. So checking the validity of the ABG, this is the graph. So usually we can, if there is a pH is 7, the log of H plus ion should be around 100 for a 7.18. You need this to convert, this chart is required to convert from pH to H plus ion concentration to check the validity. So this is the equation. See, let's check whether the ABG is valid. H plus ion concentration is given by 24 times the bicarbonate and the PaCO2. So seeing this, the pH comes by around 7.3. So for that, the H plus ion concentration should be 50, whereas our patient's is somewhere around 48 as calculated. So roughly valid ABG. So if there is a gross discrepancy, then there is an invalid ABG. This can happen if the sample is not drawn properly, air bubbles are there, the calibration is not there, there are bromide ions or others interfering with the ABG machines. So there is a host list of causes. Next will be evaluation of the oxygenation status. Here is where your alveolar gas equation is very important. To calculate what is in the alveoli, you use the alveolar gas equation. And for the FiO2, for how much liters of oxygen the patient is on, is roughly given by 20% plus 4 times the liters of oxygen. So I have already done the calculation for it. So it comes to around 258. Whereas patient's arterial PaO2 is 56. So there is a huge AA gradient. Why do we need to calculate AA gradient in a patient who has got breathing difficulties? It gives you a lot of DDs. So let's see. This is the approach to hypoxemia using the AA gradient. So if AA gradient is normal, there is age adjustment also, which is given by the formula patient's age plus 10 by 4. If AA gradient is almost equal to or mildly less than age adjusted gradients, then we think of only minor abnormality like FPO, inspired oxygen itself is less, or the patient is centrally hyperventilating. Whereas if the AA gradient is grossly less than what is expected, grossly more than what is expected for that age, then there is an additional abnormality. Additional abnormality can be a shunt, a VQ mismatch, or gross diffusion defect, as in case of interstitial disease, pulmonary fibrosis. So the moment AA gradient is increased, the student has to think that there is something abnormal in terms of in the lungs, whether it is pulmonary circulation or the ventilation or the interstitium. So there is something grossly abnormal in the lung, and sometimes, very rarely, there can be shunt in terms of cardiac also. So in our patient, we saw that the area gradient was increased, that is almost 200. So you have to now think of additional shunt or ventilation perfusion mismatch causing hypoxemia and breathing difficulty. So now at the bedside, you should think that either the patient has a pneumonia or a pulmonary embolism, or I have to elicit history whether he has any connective tissue disorders, ILD, or anything. So considering that he's a male patient, 60-year-old man, I would not think of all these causes. I would rather think of pulmonary edema or a pulmonary embolism. If he's a smoker, I would go back, take history, ask for smoking history, or any drugs like, chronic amiodarone, bleomycin. All this can cause interstitial disease, or any occupational exposure. All this I would think of in a 60-year-old man. So this is how you use it to arrive at a more differential diagnosis. In my history, all this was not available. And now that ABG is showing this, I would rather go on. On auscultation, there is completely no Krebs. I would rather think of a pulmonary embolism. So a normal lungs on auscultation. Whereas if there is Krebs and, or there is bronchi, then I would think of a pneumonia or COPD acute exacerbation. This is how you apply at the bedside. So after the easier part, this is the easier part, this is over. Next will be how do you evaluate the acid-base status. So since the pH is less than 7, it is established that there is an acidemia. But metabolic, this primary disorder is metabolic because bicarbonate is low. So pH and bicarb is going on the, both are low. So it is a primary metabolic acidosis. So the direction is important. And then the expected compensation is given by a Winter's formula. So since the actual PaCO2 is less than expected PaCO2, there is an additional respiratory alkalosis. The actual PaCO2 was 18, I believe. So the diagnosis in this patient is there is a metabolic acidosis with additional respiratory alkalosis. Now that anion gap is 17, there is a high anion gap metabolic acidosis. So why calculate anion gap? Why do you actually need this? Basically because if it's a higher anion gap, the external acids added in the system should be thought of. That is your mud piles, methanol, your uramia, DKA, iron, isoniazid, all this can cause your high anion gap metabolic acidosis. But the problem is once the anion gap is also not very fixed, it's quite a wide range. If you add potassium, it can be anywhere between 16 to 20, whereas without potassium, it can calculating the difference, sodium minus chloride by bicarbonate, somewhere around 12 to 16. So it has quite some big range that needed to be kept in mind. So this is what the concept of anion gap is. So normally sodium minus sodium, removing the summary of your bicarbonate and chloride from your sodium will give you your anion gap. It should be somewhere around 12 because of your albumin, phosphorus, all your negatively charged compounds, which cannot be measured by your ABG. Whereas once you add another unmeasured anions like your lactate or your ketones, so that brings down your bicarbonate and chloride and the gap almost widens. So this is why it is important. So as I said in previously while learning where are the acid coming from, this is where it is. It can, this is the lactate, ketone and intoxication. This is where your high anion gap is coming. Whereas normal anion gap is when you have increased loss of bicarbonate. That's where your net acid-base balance is not maintained, and then you have acidosis. This can be because of your diarrheal loss, or you're having one pancreatic fistula or an intestinal fistula, and you're doing suctioning, drain, or some surgery. This is the gastrointestinal loss. The renal loss is mainly in terms of RTS. It can be drug-induced or acquired or congenital or a part of the renal disease, like in type 4 RTA in diabetics. So after checking what type of acidosis the patient has, whether the high anion gap, normal anion gap, now you got to know that this patient has high anion gap metabolic acidosis. My patient is diabetic, possibly diabetic ketoacidosis, although lactate is 4.2. For hyperlactatemia, it should be around 5 and above for lactic acidosis, whereas 2 to 5, it's roughly it is called hyperlactatemia. Now you have to check the delta gap. So delta gap, this is also an extension for your Boston approach. This is mainly because to check that whether there is an additional normal anion gap metabolic acidosis. It can coexist. 2-3 processes can coexist in a single patient. So whether there is one more problem which is causing some more acid production in my patient. So how do you know that? For that, you have to check the change in anion gap. That is, normal is somewhere around 12. So our patient is 17. 17 minus 12 is 5. Whereas next you see the change in bicarbonate, 24 minus 9. So 24 is the normal bicarb. You deduct that and see. So there is a gross change in bicarbonate, whereas the change in anion gap is not much high. The more negative the anion gap is, there is an additional normal anion gap metabolic acidosis. If it is positive or more than +2, then the delta gap tells that there is an additional metabolic alkalosis. So all of this process can coexist. The problem with our medical education, we are taught that either the patient has pneumonia, pulmonary edema, either the patient has doesn't have both. That concept is not put in our mind. When we come at the bedside, we see 2-3 processes. We discover and we think whether it is right or not. But most of the times it is combined etiologies that is there at the bedside. So when you come at the bedside, the patient can be having a metabolic alkalosis because you gave diuretics for the pulmonary edema. He also has a high anion gap metabolic acidosis because he is in DKA. So 2-3 processes can coexist and get in. And in critically ill patient, it is more of a norm than exception to get a mixed acid-base disorder, especially by day 3, because you would have resuscitated with normal saline for sure to get one hyperchloremic metabolic acidosis. So this is the easier one. The other version is delta ratio also can be given. Delta ratio, if it is less than 0.4, it straight away tells that there is one hyperchloremic normal anion gap metabolic acidosis. Whereas if it's 0.4 to 8, HAGMA and NAGMA can be there. Or if it is 1 to 2, it can be just pure high anion gap metabolic acidosis. And if it's more than 2, metabolic acidosis. Along with that, there is a metabolic alkalosis and a respiratory acidosis. So putting it all together, what does my patient have? Our patient has an hypoxemia with respiratory alkalosis. Now we are in terms of based on auscultation and possibly lung ultrasound, I'll have to rule out pneumonia, pulmonary embolism. I would rather go with pneumonia because the clinical examination didn't show a DVT. And he has a gluteal abscess, so probably some sepsis and seeding elsewhere bacteremia. Whereas the patient has high anion gap metabolic acidosis, lactate is mildly elevated, so I'll have to do now an UKB to rule out a diabetic ketoacidosis. And also there is an additional normal anion gap metabolic acidosis, possibly because a mild elevated high chloride level. If the chloride was normal, then I have to think, wait for the RFT and see whether he has got renal issues also, chronic renal issues, and get an ultrasound of the kidney, see the kidney size, whether it's an AKI, CKD, all these things should be kept in mind. So to summarize, the patient has a triple disorder, high anion gap metabolic acidosis, respiratory alkalosis, and normal anion gap metabolic acidosis. This is how you summate everything and think when you get the ABG. So this is another case. He was perfectly healthy, 25-year-old, 24 hours ago. Then he developed severe watery diarrhea. So history itself, it is clear that we are losing base here. So because the large colon watery diarrhea, it's rich in bicarbonate fluid. So he has not taken any food or water, and he has noted very little urine output over the last few hours. Blood pressure is low, and JVP is also low, and pulse rate is high. So acid base shows that he has mild, almost normal pH. Bicarb is normal. How surprising. We expected a low bicarb, but bicarb is normal. His PCO2 is also normal, but his anion gap is 24. His diarrhea volume, if you ask his history, it is around 5 liters. And if you check, I'm just curious, what is happening with this patient? He has diarrhea, he has lost bicarb, he should be acidotic, but we are not getting any acidosis. And incidentally, when I send a CBC and LFT, I see that his hematocrit has increased and his albumin is 8. Why so 8 albumin? Do I have to think of causes of hyperalbuminemia? No, just slow down. The cause is mainly because of volume contraction. So does this patient have a significant degree of metabolic acidosis? History-wise, yes, but why is the ABG lying? And what is the cause for high anion gap in this patient? So if you use by strict definition of metabolic acidemia, the patient does not have any such disorder as per ABG. But clinically, patient is in ICU, he's having low stools, his BP is low, his JVP is low. What to do? It is because the very high albumin is because there is a profoundly contracted extravascular volume. So what has happened is, when you, is just a simple logic. You put little more salt, you put a spoonful of salt in a small glass of water, the salt content is high. If you put a spoon of salt in a mug, the salt content is low. So what happens is, if your extravascular compartment is contracted, rather than addition of new acid, what has happened is, whatever, despite you losing the base, the bicarb has still normalized. It appears normal on the ABG because the volume is contracted. Where is the evidence of volume contraction? That's because that is seen in your hematocrit and your albumin. So when you see a falsely high hematocrit or albumin, remember that the patient is maybe volume contracted. So this is when you should use a corrected albumin level for your anion gap. That is, for every one change in your 2.5 change in your albumin, you have to one change in your anion gap has to be added. So the lessons learned is, trust your patient, correlate clinical and laboratory information, don't treat the ABG, please treat the patient. So another case is, this is a patient, 50-year-old, he's a chronic renal failure on maintenance hemodialysis. He has missed his last dialysis session and now he complains of breathing difficulty. Is a case of COPD on inhalers. He's now giving cough with pink frothy sputum. So history-wise itself, it is looking like pulmonary edema, and his room air saturation is 70%. So this is the ABG done in emergency. This is gross acidemia. PCO2 is high, so there is a respiratory acidosis. Oh, bicarb is also low as expected, so there is a metabolic acidosis. Sodium is okay, mild hyperkalemia, part of his CKD. Chloride is mildly elevated. Lactate is elevated, okay, explained by pulmonary edema. Anion gap is high, yes, it's part of chronic renal failure. Hypoxemia, secondary to pulmonary edema. Everything is explained. So what is the acid-base disorder and what is the clinical diagnosis? First, you have to check the validity of ABG. The H plus ions comes to 80%. So for that, the pH should be 7.1 and the patient's pH is now 7.1. So the ABG is valid. So oxygenation status, we expected pulmonary edema, AA gradient should be more. So he has a expected normal age adjusted AA gradient should be age plus 10/4, so that's around 15. He has a AA gradient of 47, so this is expected. So along with your VQ mismatch secondary to pulmonary edema, there is a hypoventilation. So this is what there is nothing surprising here. So there is both metabolic and respiratory acidosis. What is the primary disorder here? This is a common question because both bicarbonate is low and PaCO2 is also elevated. So for that to know, you have to see the change as how we saw delta A anion gap and delta bicarbonate. You also, here also we have to see the change in bicarbonate in terms of percentage and change in PaCO2 in terms of percentage. Which is the dominant disorder? The percentage change in bicarbonate here is little high, that is 37%. So the majority, at least the more contribution is now from your metabolic acidosis rather than respiratory acidosis. Since anion gap is elevated, there is a high anion gap metabolic acidosis. So is there any additional normal anion gap metabolic acidosis? That's how for that we have to do delta gap, which is -1, which is normal. So there is no additional acid-base disorder. So to conclude, this patient has clinical diagnosis is chronic renal failure, COPD, and with high anion gap metabolic acidosis and respiratory acidosis. The cause of hypoxemia is due to pulmonary edema, mainly because of missed dialysis, and the VQ mismatch is mainly because of, you have a lot of VQ mismatch in COPD patients, that also is there, and possibly some amount of pulmonary edema also. So case 3, this is a 73-year-old woman. She has got rheumatoid arthritis. She is on home oxygen. She has increased her dose of aspirin because she's now having extreme high pain. Then after aspirin, she developed epigastric pain and she vomited frequently for 2 days. Then she went to local hospital. Her saturation is low, but it reaches 92% with 10 liters of oxygen. pH is grossly alkaline, 7.7. PaCO2 is low. Anion gap is high, whereas there is hypoxemia. For 10 liters of oxygen, having a PaCO2 is low. Lactate is also elevated, and bicarb is high. So what is the ABG, and can you give a clinical diagnosis? So I'll just stop here for a moment and discuss with the audience, because I'm just feeling quite monotonous. So can anyone tell what do you think is the clinical diagnosis here? Sorry about this. Anyone, what is your diagnosis?
I think students can type it on the chat box. Shivkumar?
Yeah, please. Yeah, students are requested to type in a chat box.
Overload.
No, the basic. Students are requested to type your answer in a chat box.
One answer has come as volume overload.
You need to type acid-base disorder. What kind of primary acid-base disorder it is? Based on you can give a stepwise. You can type the answer. So one answer has come: respiratory alkalosis.
Okay. What about the metabolic disorder? Okay. The patient has respiratory alkalosis and metabolic alkalosis. Fair enough. Do you even consider that there is a possible metabolic acidosis? Okay, let's go and see. So the ABG is valid. We have checked the validity of ABG. Just minimize the chat box. So let's see the AA gradient. AA gradient is quite big because you're giving 10 liters of oxygen. The PaO2 expected is 40, whereas the alveolar PaO2, whereas the arterial is just 60. Sorry, this is not working now. So there is a huge AA gradient, 341. Normally expected is somewhere around 20. So definitely there is a hypoxemia. In this patient, I want you all to think of interstitial lung disease, because the history is there that she's on home oxygen. Rheumatoid arthritis is known to cause ILD. So that is one thing that should have come up in most of your answers. And another thing is repeated vomiting. 70-year-old lady, very high vomiting. Sometimes they can aspirate and they can develop pneumonia. So these two things would have come. If you go stepwise, you will not miss this. If you directly went to the despite what the question being on acid base, you should always go stepwise and should not miss any step. Since you missed the step of AA, analyzing the AA gradient, we now lost a diagnosis of interstitial lung disease or an aspiration pneumonia. So this is very important to be very methodical. As student, it is very good to have some degree of OCD for perfection to not miss such kind of an illness. So she has metabolic acidosis, as someone answered. That's very good. She also has a respiratory alkalosis. So there is a 2 acid-base disorder, and there is a small rise in her plasma anion gap, possibility of 3rd acid-base disorder, that is high anion gap metabolic acidosis resulted from added acids. It could be your salicylic acid as seen aspirin and lactate, because that also should not be missed. This is the most likely diagnosis. So you should think of all the possibilities because if you do not think of all these possibilities, you will not treat the patient. So that's where it is very, very important to understand that this patient might have overdosed on her aspirin. So next you would, for that, you will actually go for talk to the renal your nephrologist and get the hemoperfusion, whatever required for salicylate poisoning. So the clinical diagnosis is salicylate poisoning with a metabolic alkalosis, respiratory alkalosis, and high anion gap with hypoxemia secondary to aspiration pneumonia and an ILD. So the whole picture has to be made, because if you do not treat for that particular disorder, the patient will not get better. So just a small note on urinary anion gap. This is important because it is, although it's not part of your ABG analysis, if you're not getting answers through this, and there's an entity called renal tubular acidosis to diagnose that and to differentiate between gastrointestinal or renal cause of your bicarbonate loss. So you need to calculate the urinary anion gap. This approach is required to differentiate between the sub-causes of normal anion gap metabolic acidosis. Once you diagnose normal anion gap metabolic acidosis, there is no GI loss. Now you have to think, where is the loss coming from? Where is the bicarbonate? Where are they lowing? Whether it is a proximal RTA, whether it's a distal RTA, whether it's drug-induced RTA, whether RTA is there or not. All of this, you get a picture by seeing the urinary anion gap. It is usually positive. It's nothing but your sodium plus potassium minus chloride. See, this chloride, you cannot measure the urinary ammonium. As I said, is the kidney excretes the additional acids in terms of ammonium ions. So what happens is ammonium ions are generated by degradation of glutamate. So glutamate is now converted to ammonia and excreted in urine. Why? During this process, a new bicarbonate ion is generated that is reabsorbed into the blood, and that's how the acid is balanced by generating a new base. So this is how the kidney compensates for any acid disorders, and this is why if you see that acute the chronic metabolic acidosis, the compensation is much more compared to acute metabolic acidosis. Why? Because kidneys take time to degrade the glutamate into ammonia and excrete that ammonia into urine and regenerate a bicarbonate during this process. This is why is the kidney taking time? This is not a preferred pathway by kidney. This happens only in case of a metabolic acidotic process going on for few days. Why? Because if you start degrading every glutamate that is exposed to that the kidney gets, what happens is your muscle mass comes down. So this is actually a protective mechanism, and this also explains why kidneys take time and why the compensation is more in terms of chronic metabolic acidosis, that is 4. Every 10 decrease in your decrease in your bicarbonate, you will get 4 increase. Why? Because kidneys are generating new bicarbonate ions by excreting ammonium ions. This ammonium ions normally combines with chloride. So by measuring urine chloride, we cannot measure ammonium ions. No lab measures urinary ammonium ions. It is difficult to measure since ammonia is excreted. Ammonium ions are excreted as ammonium chloride. So what we do is you calculate urine sodium and urine potassium, and you measure that. You subtract the sodium and potassium from the chloride levels and see, usually it is positive because it inverse of the excretion of ammonium ions. But if it is, the loss is mainly because of bases by gut, like in diarrheal illness, what is the kidney is supposed to do? Kidney is supposed to retain all the ammonium ions, and what happens is urinary anion gap will become more and more negative. Whereas if the loss is by the kidney, it is usually, this leads to a decreased urinary anion gap remains almost unchanged. So this is very, very important. So by knowing the urinary anion gap, you will get to know that the base is of renal origin. The base loss is by renal origin or by your gastrointestinal origin. So decreased urinary anion gap is what that is normally expected, and that's how it should be there. If you do not have, then the loss is by the kidneys. So the pitfalls of Boston approach. So you will get to know, let me just give this example. This is a ABG where the pH is 7.2, PaCO2 is 80, of course, respiratory acidosis. Bicarbonate is 33. So usually for acute, this from 40 to 80, it has gone up. So if it is an acute disorder, your bicarbonate should be 28, 4 increase, no? Should have been there for every 10 rise in PaCO2. If it is a chronic, it would have been 36, but that is not there. The bicarb is 33. So what is your conclusion? Either it's a mixed disorder or it's an acute on chronic disorder. So also there is an acute change in PaCO2. The pH should have been 7.08 because 0.08 drop in every 10 change in pH. But here the pH is 7.2. So how do you decide what is the patient having? It looks like a partially compensated respiratory acidosis on a first glance. On the contrary, it can be a respiratory acidosis acute with some metabolic alkalotic component causing a mild rise in your bicarb expected this thing. Or it can be an acute acidosis on a chronically compensated respiratory acidosis, bringing down the expected bicarb from 36 to 33. So all three processes can be there. So Boston approach can really not tell you what is happening at the bedside. It cannot provide you the diagnosis. So, and it cannot differentiate by a single glance, which is primary. You have to calculate by percentage what is the primary change. Complex equation you have to memorize, and it does not give you the magnitude of disturbance. And etiology pathway, as I told, cannot either, and difficult to understand mechanisms. These are all the pitfalls of Boston approach. So to summarize, the whole point of the talk was to take proper history and complete clinical examination and then go pick up your ABG and read, because if you read just your ABG, it will not give you diagnosis. You will end up treating the ABG but not treating the patient. I thank you all for having such a patient listening and giving me an opportunity to speak in front of you all. It feels really good to start to talk in front of all my mentors, and thank you for a patient listening.
Thank you, madam. Thank you for a vast and insightful lecture. Azam sir, over to you. Open for discussion. Just a brief discussion. It's already late. If anybody has a question, please go ahead. Murli, sir. Gurdat sir.
Yeah, excellent talk as usual. I have seen her speaking so many times. No comments from my side, no questions also, because everything was completely, cleared. Because ABG itself is, for majority of the students, it appears like a very complicated thing, but she made it very simple. And ABG is also my favorite, subject as such for teaching students. So thank you so much. Very well done and excellent lecture.
I had known that majority of the
Hello.
listeners are doctors who are stalwarts here, like here. I would have rather talked on Boston and Stewart and Copenhagen approach rather than Boston. So, anyways, thank you all for patient listening.
Hello, Nazim.
Ravi sir,
Dr.
please.
Ravi sir, please go ahead, sir. 1 or 2 questions will be allowed. That's it. Yes, sir. Yes, sir. Ravi sir.
Wonderful presentation. Yeah. For the students, because there are about 20-25 blood cases to be read, would you like to have one say that how to interpret rapid blood gas analysis? Like you have to have, there are 20 patients there in ICU or maybe in cardiac surgery, post-cardiac surgery. You have to go with rapid interpretation. Can you have 1 or 2 points about rapid interpretation?
First thing is, do not miss any hypoxemia. No matter what, don't miss, because you will end up missing one pulmonary embolism definitely in ICU. So AA gradient should never be missed. You can't do it. Ask your nurses. Give a nurse one ABG and tell them to calculate the AA gradient and give it for you. That's a must. Second thing is, when you see a normal pH, it's a red flag. In ICU, patient cannot have normal pH. The patient should be in ward. If he is in normal, you have a normal pH which is normal in ICU, definitely the patient has mixed disorder. Spend more time for that patient. Then simple disorder, respiratory, ABG which is correlating well with clinically, do not worry. Okay. The moment the ABG is not correlating with clinically, see, you are expecting a COPD patient, respiratory acidosis on NIV. Next day you expect a compensation coming up and pH normalizing, but in fact the pH has over normalized. That's where a red flag, because that means to say you have caused a volume contraction, metabolic alkalosis, because you gave a Lasix thinking that this patient has RV dysfunction because he has cor pulmonale. So you have caused an additional disorder there. That's patient you should be cautious, because he is going to collapse soon if you do not regularly correctly resuscitate him and stop that Lasix that was given for him. So usual practices, this happened to me in my PG days, that on blood transfusion it's very common to give off one Lasix. But if you, before giving that, if you had seen the AB, the patient already has a bicarb of 33, I would rather think twice before giving that Lasix. So what is not correlating clinically, you should have it in your mind when you're seeing the patient, that I expect this pH to be like this, the PCO2 to be like this in this patient. And if it is not correlating, that's the red flag. Never miss an AA gradient, because you will definitely pick up one pulmonary embolism. And always keep a watch on your bicarb. Falling bicarb, check your urine output, call your nephrologist, make sure that the patient will not have goes into this vicious cycle of worsening acidosis and worsening shock, and you cannot dialyze. You should have intervened 3 hours before, 6 hours before. I missed this. This should not happen. So keep a watch on your bicarb and never miss your AA gradient.
Madam, to add whatever you have said, I think excellent presentation. Even my topic is ABG, my favorite. So whenever we, that's what I think what Ravi sir was trying to find out was, whenever we get a anion gap, metabolic acidosis, the second step would be to calculate anion gap. Anion gap, high anion gap, I think you have told, mud piles and CAT. That's fantastic. But there is a possibility, just for the students, there is a possibility where you can have a normal anion gap metabolic acidosis, which you have mentioned somewhere in the talk, and also lower anion gap. So the easiest way to remember normal anion gap, where there is metabolic acidosis, but the anion gap is normal. So it is HARDUP, H-A-R-D-U-P. Hyperalimentation, H-A is for acetazolamide, R is renal tubular acidosis, what you are mentioning, 1, 2, and 4. H-A-R-D is diarrhea, U is uterosigmoidostomies and pancreatic fistulas. And there is also, for example, a patient with PIH or patients with nephrotic syndromes, you get metabolic acidosis, but with low anion gap. One thing is anion gap cannot be negative. If you're getting a negative anion gap, I think we are somewhere something has gone wrong. So if you get a low anion gap, we have a couple of causes like hyponatremia, nephrotic syndrome, multiple myelomas. So I thought this would help these guys, students. Thank you so much, ma'am. That was an excellent discussion.
Thank you all for patient listening.
I think is time up. We'll wind up the session. Thank you very much. It was an excellent lecture. Both the speakers have presented an excellent this thing. I thank Dr. Natesh and Dr. Sumulata for excellent talk. I also thank Dr. Azam for a wonderful moderation. Thank all the academic advisors for insightful discussion, especially Dr. Gurudat sir and Ravi sir. I thank all the delegates, postgraduates, and Ms. Shilpa from A1 Logics. Thank you all. Thank you.
Thank you. Thank you, sir.
Thank you, Shiv Kumar. Thank you,
Thank you, sir.
speakers. Thank you very much.
Thank you, sir. Thank you.